Respected teachers, dear colleagues, ladies and gentlemen, I thank IPDI for this wonderful opportunity of being here today. I think I commend Dr. Mohsin, Professor Abdul Chaudhary for their tremendous endeavor in making this happen. It's really a wonderful scientific exercise. Today I'm supposed to talk about intervention for disease of the aorta, progress and prospects in Bangladesh. But before I go into that, please allow me a couple of seconds or a few seconds to pay my respect to the father of the nation. Today is his birthday, and we all know and agree that if this man was not born in this soil, it would be difficult for many of us to engage ourselves in these sort of scientific activities that we are doing today. The month is important because he was born in this month. He delivered his historic speech on 7th of March, and 26th is our Independence Day. So it's a tremendously, hugely important month for the nation that is Bangladesh today. This is where I work in IPDI and Bangladesh Specialist Hospital. So many of the works that I'll be talking about today were actually done in these two institutions. I'm excited to tell you that NICBD has vertically extended, and we, the vascular surgeons, the Department of Vascular Surgery has got tremendously increased floor space, and from now we'll be able to accommodate more patients and be able to do more and more procedures, including interventions. Probably we're going to have a hybrid OT as well that will allow us to do a lot of complex procedures that is not possible as of now. So aorta, as we know, is the superhighway of the body circulatory system. It's a gateway to the lymph circulation, arterial blood flow, and any blockade in the artery can be compared with the Farakka Dam that hampers the river flow in Bangladesh. So issues with the aorta is that we can have stenotic diseases like aortoiliac occlusive disease, we can have coarctations, we can have aneurysms, dissections, of course we can have the penetrating aortic ulcers. I will not be spending much time on the occlusive diseases because this is one of the sectors that we have been pretty familiar with, and we have been dealing with it for the last few years, and with very good results, I can tell you right now. So it has been said that the surgical option versus the endovascular, and over the years all around the world, endovascular approach has been compared favorably against the surgical options. So this is what we do day in, day out at many institutes in this country, kissing stents to treat the aortoiliac diseases, even the complex ones like this one. In the patient Takasis arteritis, we did this complex aortoiliac reconstruction with satisfactory results. So this is the scenario right now in Bangladesh, that we have about half a dozen centers who are capable of doing these sort of things. We have more than a dozen expert vascular surgeons who can do it. We're doing more than 200 cases annually of aortoiliac revascularizations. The growth is good, but I can tell you that there is a certain deficiency in the steady supply of the hardware that are required. We are lacking behind in CERAP procedures, the covered endovascular reconstruction of the aortic bifurcation. The concept is here, but it's not easy to get the hardware all the time, with expenses also there, and the indications are also poorly defined. So as of now, we are not doing a lot of CERAP cases, but other things we actually do quite well these days. But we should not forget the place of surgery in case of aortoiliac occlusive diseases, because there are cases that will ultimately need surgery. So coming to the aneurysmal diseases, we have lesions like this presenting to us all the time, and we have started doing this by endovascular means, by interventions. The results has not been really great all the time because there is a steep learning curve, as I've said. The first case I remember when we did it at NICVD, we ended up occluding the ipsilateral limb while doing the contralateral revascularization. Then we needed to have the fem-fem crossover bypass the next morning. So you will agree that there is a steep learning curve in this sort of sophisticated interventions on the aorta. So this is the current scenario in the non-occlusive pathology of the thoracic and abdominal aorta. It is done sporadically in Bangladesh, not very routinely. The first case was done in 2014 for AAA. We have done fenestrated endograft, not chimneys. We have done so far more than a dozen cases I can remember, mostly done for thoracic and abdominal aortic aneurysms and for penetrating aortic ulcers. But we have not done any case for dissection. affordability has been an issue because we come across cases quite frequently, but not all patients, not even a few of them submit to the interventions in the end. This is thoracic aortic aneurysm. The case on the right-hand side, this one probably is going to be done in a couple of weeks' time. We're preparing for this one. So we did TIVAR in the past with good results, without any paraplegia or any complications. So these are the positive learning experiences that we had so far. We can have this sort of cases as well, where the occlusive pathologies combine with the aneurysmal, and so difficult cases to handle. We did penetrating aortic ulcers in a patient on hemodialysis, renal failure patients, and the result was really, really good. This is the 1-year follow-up CT angiogram, the endograft sitting very nicely without any distal or proximal landing zone complications. Like I said, we did not intervene on dissection cases as of now, but in the years to come, that has been one of the targets that we have to reach. The personal data has been that in the last few months only, more than a dozen cases have come to me only with different types of dissections and aneurysms of the thoracic and abdominal aorta. We have walked these patients up for possible interventions, but ultimately we did not or could not. It indicates that there is a positive growth in the rate of diagnosis and referral. But probably it also points to the lack of affordability and probably lack of confidence from the patient side on the interventionist. So with these concluding remarks, I will finish. Aorta has been a focal point in the field of interventions nowadays, worldwide. The trend in treating aortic pathologies has a large swing towards intervention compared to surgery. But aortic interventions remain a very hardware-intensive and technically demanding undertaking. In the absence of insurance support, affordability will continue to remain an issue for non-occlusive aortic pathologies in countries like Bangladesh. But I want to remain hopeful that the country is developing economically, and it will not be far that we'll be able to do more and more cases, and it will become a routine procedure like the aortoiliac occlusive disease cases. So the days is not very far when we will be doing these sort of cases on a regular basis. Thank you very much for your attention. This is one of the books I wrote, and I invite all of you to kindly have access to this book and read it and give your feedback. Thank you very much.